Good morning, everybody. Welcome to Cold Water Immersion. Uh, are very lucky today to have Dr. Weiche, our MPD, who's going to present. And we'll hold questions. We got questions, you can throw them in the chat. Got to them at the end as well. All right, Dr. Weiche, it's all yours.
Okay, well, good morning, everybody. Today we're going to talk about cold water immersion, and we're going to talk very specifically about who do we resuscitate, and of those that we do resuscitate, how do we do that, and what are some of the important issues? There was a couple recent cases that came up that kind of brought this issue to the forefront. And we found out from these two cases that there was a lot about cold water immersion and hypothermia that we could have done better, and things that are important to recognize with cold water immersion. So this is one of the cases, and this was a 58-year-old female. And if anybody here was involved in any of these cases, feel free to chime in and give any input or insight you had if you were involved in these cases. But so this one, 58-year-old female, she had recently been discharged from the hospital, had been admitted for suicidal ideation, and she, had apparently left a note of her intentions to commit suicide. And so the police department was looking for her, and based on a tip, they went out to Bellingham Bay and saw her car parked there. So they figured she must have been there. So they were walking up and down the shore and saw her floating, and they waited out there to pull her in. So the Bellingham police started CPR and placed an AED. Interestingly, the AED had recommended a shock, and there was two defibrillations from the AED prior to the medics arrived. When the medics arrived, they also defibrillated once and started CPR and brought her into the emergency department. She was apneic, pulseless, unresponsive. So this is an example of a very common scenario. You pulled somebody out of the bay. Uh, did they drown? Are they hypothermic? Do we resuscitate them, or do we not? This is her intubation, and you can see some silt there on the back of the airway, um, which is commonly associated with drowning. And you can see there's that yellowish material in there. Don't know what that is. I suspect probably had overdosed on some pills prior to jumping in the water. And then our second case is a very dramatic case of a couple that were in their mid 50s, and they were on their sailboat when their rudder broke, and their rudder was stuck to the starboard side, and they had lost control of their boat, and it began to blow into some rough seas. And they uh, sent out a mayday call that was initially picked up by the Canadian Coast Guard and then transferred to the US Coast Guard. And the response was to send the Coast Guard that is stationed here in Bellingham on their 45-foot rapid response boat. And after that boat had been out there, later the Coast Guard dispatched their Dolphin helicopter from Port Angeles to assist. And this is footage from the Coast Guard fast response boat to the uh, to the sailboat. So you can see how wildly it's pitching. You can see the boom is out and the sails are ripped and they're out. And you can see how unpredictably it's pitching. And then I think here what they're trying to do is they try to come alongside and the crew was on the side of the boat, gunnels down, and they were trying to get uh, the passengers on that boat to come over, but they weren't they weren't responding. And apparently, you have to be very careful with sailboats. If you get too close and you touch the side of them, their hull is pretty fragile and you can crack it. So they had to be very careful that they didn't capsize the boat and they didn't uh, injure, break the boat. So they're trying to get them on board. Can't get them on board. So they were unable to get the two on the boat. And the plan was they were going to let the boat run aground so that they could try to drop a swimmer to get to the boat once it was stopped pitching. The dolphin showed up, but they weren't able to lower a rescue swimmer because of the way the boom was swinging around and the way the mast was pitching. There was no way to lower a swimmer. Uh, and once the sailboat ran aground, it held steady for a moment, allowing the rescue boat. They actually decided to ground their boat in an attempt to reach them. And then the mast actually broke and fell on top of the uh, Coast Guard boat, causing some minor damage. But when that mast broke, then that now allowed the Dolphin to drop a rescue swimmer on the boat. And so that's what this is here. The the Coast Guard swimmer being lowered onto the sailboat that's now grounded. So the swimmer got down. There was a couple there. The male was uh, right next to the swimmer, so he hooked up to the male and pulled him up into the helicopter, lowered him into the boat, and then went back for the female, and she wasn't on the boat. And they looked for her in the water, and the fast response boat saw her floating face down. And the boat was able to rescue her, pull her out, and bring her on the boat. And she was pulseless and apneic when they brought her on the boat. And they had estimated that she had been in the water for only 5 to 10 minutes. And so then the Coast Guard flew her uh, into St. Joe's, and it was kind of one of those confusing situations where the Coast Guard had showed up, but hadn't notified anybody that they had arrived. And there was a BLS crew and an ALS crew that were going in service and heard the helicopter land. And they actually went out there and put the patient in the back of the medic rig and intubated and brought into the emergency department. And also, interestingly, the Coast Guard said that they had placed an AED in the helicopter and had delivered 2 shocks, and then no shock was advised, and they continued CPR when they got to the emergency department. And this was that intubation, and you can see actually went in pretty deep early, but so you're kind of looking into the esophagus right there, but you can see there's a lot of bloody fluid that is in the posterior pharynx. also probably most consistent with the drowning. And you can see the bloody fluid coming out of the airway. And there's still a little bit of pink froth in there. So the conundrum with cold water immersion is there's this axiom that is they're not dead until they're warm and dead. And so that's what this talk is to address. I push back against that axiom because the question is, did they get cold and die, or did they die and then they became cold? And so who are the patients that are uh, arrested because of primary hypothermia versus secondary hypothermia, because those are the patients that we want to resuscitate. So we have to try to distinguish between the people who drowned and those who didn't. So this is kind of the theory behind why you want to be aggressive about resuscitating somebody who is hypothermic, and that is that as your core temperature drops, your brain metabolism also drops. So if you are profoundly hypothermic, it has a protective mechanism for protecting the brain against prolonged hypoxia. And that's why we are often aggressive about prolonged resuscitation and warming hypothermic patients. And we know that there are different temperatures that are associated with the depth of hypothermia. This isn't really useful to you out in the field because you're not going to know what their temperature is. And even when you do get their temperature, it's going to be very different depending on where you check it. And that was kind of the thought behind this Swiss hypothermia staging system, where it used the clinical findings to correlate with core temperatures. And so that allows the first responders, the medics, when you come across a patient who's hypothermic, to have an idea of which category of hypothermia it is. This Swiss staging system has recently been simplified specifically for pre-hospital folks to make it a little bit easier to use, with the 4 stages of hypothermia correlating to the AVPU clinical finding assessment and correlating that to the risk of cardiac arrest. And mental status is one of the best barometers for how somebody is doing systemically, and that's certainly true of hypothermia. Their mental status is associated with their risk of death and cardiac arrest. In our waters here, we primarily think about the sound. We don't have the frozen lakes as much here, although when Paddon freezes over in the winter, sometimes that's different. But the waters that we have out here are typically in the upper 40s, lower 50s. And so if somebody is in these waters in the sound, you can see in this graph, they have to be out there for quite a while before they have the potential to even become hypothermic. Whether they're going to become hypothermic is based on individual characteristics, and so can be variable. But some rescue coordinators use this cold exposure survival model to decide whether somebody might potentially be hypothermic and whether they should continue to look for them and whether they are survivable or not. So that data kind of gives you a graph looking like this, and you can see the 50-degree line is close to what we have here in our waters. And after you can be in there for about an hour, and maybe, and this is very conservative, so this is really on the outside of what is possible, that you could be out there for an hour and still being able to tread water. But if you're out there longer than that, you can be hypothermic, but you may not survive without a life jacket. And so this is one of the more important slides, and it's related to whether you have a life jacket on or not. And that will have a profound implication for who you're going to continue to look for and who you can expect to survive. So you can see in line B there, if you have a life jacket and you're floating in water, and particularly if you have a class 5 PFD or you're in a life jacket that allows you to float with your head up, you can survive out in the water a lot longer than somebody who does not have a life jacket. You can see in line B that as long as you're conscious, you'll be able to tread water. But after you've been in that cold water for a while, your consciousness begins to wane. Even the strongest swimmer among us is gonna drown without a life jacket. So the issue is that it's impossible to die from hypothermia in cold water unless you're wearing flotation, because without flotation, you're not going to live long enough to become hypothermic. And we'll talk about why that is. So what we're trying to distinguish is, did they drown or did they become hypothermic? Some of the things that you'll see that are more associated with drowning are pink white froth coming out of the airways. They'll be plethoric or asphyxic. Their face will be blue. There's so-called washerwoman's hands, with means that they've been in the water for a while. And there's the so-called traveler's abrasions, where you'll see abrasions on the forehead and the back of the hands and the knee and the dorsum of the feet, which means that they've been floating in the drowner's pose for a while. And so those are all more consistent with drowning. So I'm going to talk about cold water immersion and how you die from cold water immersion. And there's essentially four stages in cold water immersion, stages associated with time, but you can die in any one of these stages. The first one being cold shock. Cold incapacitation is stage 2. Stage 3 is the hypothermia. And then stage 4 is the post-rescue collapse when we intervene. So we're going to go through these four stages. So just a brief little historic interlude, because it's interesting that for the longest time, we thought people drowned in the ocean just because they weren't good enough swimmers. And in World War II, when tens of thousands of sailors were dying, and they started to investigate this, they found out that, well, most people didn't die because they weren't good enough swimmers. They died because of the cold water. And that's why their life raft didn't work. It involved you hanging on to the line on this Carly life raft. But if you got too cold and weren't able to hang on, it wasn't doing you any good. And I think if we're going to talk about the history of hypothermia, it's probably worth remembering that dark part of the history, that the Nazis did experimentation on the people in Dachau. They did hypothermia experiments on humans, where they would make them hypothermic in ice water and then put them in hot water and see what would happen. So obviously the ethics of that are clear, but then there are ethics that still continue today, debating on whether it is ethical to use the data that was obtained in such an ill-gotten way to understand hypothermia. So back to our stages. The first stage is the cold shock. And so the cold shock response is the initial response, and it can be deadly all by itself. And so when you are first exposed to cold water, you develop this cold shock response that can last for anywhere from 30 seconds to a few minutes. And 20% of people who die in cold water die from this cold shock response. So you get this, when your body is exposed to the cold water, you get this gasp reflex. And that's been measured to uh, uh, that a person will rapidly inhale up to 2 liters of air as part of that gasp reflex when you get into the cold water. And if you fall in the water or your head goes underwater and you have that gasp reflex, you can drown just from that initial gasp reflex when your head is under the water. It's also kind of interesting that they're starting to tease out that there might be another mechanism by which people die in this cold shock response. And it's this so-called autonomic conflict between what I just described as the gasp reflex. When your body is in cold water, it's a very profound sympathomimetic response. So your heart rate goes up, your blood pressure goes up, very strong sympathetic drive. But if your face goes underwater, you get a profound parasympathetic response with your face underwater, and that is the so-called dive reflex. So if your heart is getting this profound sympathetic and parasympathetic response at the same time, that can lead to dysrhythmias. And so that's thought to be potential cause of death during the cold shock response, particularly in older people or people who may have cardiac risk factors.
But the frigid water is still very real, just 2 degrees above freezing. It immediately startles the body in what's called the cold shock phenomenon.
Get to some area where you can get some stability and just let the gasping, it'll die down after about a minute. What happens when you get really cold, your skin, whole skin starts a cold shock response, which gets you first start gasping and hyperventilating and breathing way more than you need to. And that's really bad if your head goes under the water when you gasp the first time. And you drown immediately.
Though hard to believe, in this terrifying situation, you may actually have more time than you think.
The cold shock will last, depending on different people, between 1 and 3 minutes. And the real important thing to know is that you'll get over that. You don't practice it, but just trust me, you will get over it. So if you do ever fall into cold water, the main thing you need to think about for the first minute is just not drowning. You don't have to get out. You don't have to do anything else. Just get over that. Just try and get your breathing under control. And when that happens, then you've got some time to try and do other things like get out.
So, thinking about our case from the Coast Guard, if she died so quickly after falling in the water, she probably died of that cold water response. So the second stage is the cold incapacitation. And so that's when you've been in the water for long enough that you start getting vasoconstriction of your periphery, of your limbs, in an attempt to try to warm your core. And it does work in keeping your core warm initially, but obviously as you become vasoconstricted, you begin to lose control of your limbs. And even the strongest swimmer among us, once you develop the cold incapacitation, you're unable to continue to swim, and that's when you'll drown. And this is what I was talking about, particularly if you do not have a life jacket on, you will succumb to this and you will drown without a life jacket. And so it's thought that over 50% of people die this way.
I'm feeling pretty cold and I'm getting pretty weak. All right. Actually, I'm not sure. I actually don't think I can get out of here from this one. Okay, so as it is, I can't get out of here. So the bottom line is, unless somebody comes to rescue me right now, I'm basically gonna become unconscious and drown. Well, I've got actually a long time before I would die of hypothermia. So what I want to do right now is widen the window of opportunity for the rescue team to get here. If I haven't gotten out of here within 5 to 10 minutes, I'm not going to get out. So if I just thrash around, I'm going to lose more heat and I'm going to get exhausted and I'll drown even quicker.
So the third stage is a hypothermia, and this is what we were referring to about how your metabolism, specifically, or importantly, your brain metabolism slows down as you become hypothermic. And these are the patients who are potentially survivable. These are the patients that we could potentially save if they are unconscious, pulseless, apneic, but are still survivable if we recognize them as being hypothermic and do the right thing.
People are often surprised when I tell them that you could live for an hour or two in ice water if you do everything right. But we all know about the Titanic, and we've heard stories of people in lifeboats who listened to screams for an hour or two from the victims who were in life jackets, so they didn't drown. So they actually lived long enough to die of hypothermia. People are often
So the fourth stage is the post-rescue collapse. And so this is after we pull them out of the water. If we're not careful how we handle them, they could be in a pseudo PEA, which we'll talk about. And if we handle them too roughly, we can put them into ventricular fibrillation, which will be impossible to cardiovert or defibrillate until they are warm. And if we do not warm them properly, we can also make them worse through the afterdrop phenomenon, where the colder extremities begins to warm and sends that cold blood into the core and further drops their core temperature.
In the water, Dr. Giesbrecht's body temperature may have fallen half a degree. While warming up, it actually loses another degree in what's known as the afterdrop. And this causes intense shivering. But with the help of a hot beverage and a body heater, the professor's core temperature returns to normal in about an hour.
So there's this 1-10-1 principle where 1 minute, 10 minutes, 1 hour if you die within the first minute or so, that's related to the cold shock phenomenon. After 10 minutes or so, if you die, it's related to the cold incapacitation, and you need at least an hour for you to become unconscious related to hypothermia. So if we are going to resuscitate somebody with hypothermia, the first question we have to answer is, did they get cold and then die, or did they die and then get cold? And that is where we are going to use all of that information we just talked about to help us decide, is this a patient that we are going to aggressively resuscitate, or have they drowned and they already are dead? And what are we going to do? And so this is just to give you an idea of what we do in the emergency department. As they talked about pre-hospital, be sure you handle them carefully. keep them horizontal. They're profoundly hypotensive. They have cardiovascular collapse. You need to keep them horizontal to maintain whatever perfusion and blood pressure they have. If you try to sit them up, they're going to go into a collapse. The classic burrito wrap is what you do to prevent any further heat loss. You will modify your ACLS protocol a bit, which we'll talk about. And when you're checking for a pulse, they will initially during that cold water response be tachycardic, but at the point to where they are hypothermic, they are going to be bradycardic, and you have to feel for a pulse for an extended period of time before you decide whether to begin CPR. So, because if they are just bradycardic and their heart rate is in the 30s, and you start CPR, you can initiate ventricular fibrillation. So you want to make sure that they don't have a bradycardic rhythm, and which would be a perfusing rhythm. So be sure and check for a pulse for at least 60 seconds. And unlike our typical ACLS, we're going to continue CPR for a long time, an hour, maybe two, if we are truly trying to resuscitate a hypothermic patient. So we will continue CPR with these patients. And if they are truly hypothermic, we're rescuing these people from some challenging environmental situations. For the purpose of this talk, I'm talking mostly about cold water immersions and in the sound. If they're profoundly hypothermic, it can be permissible to have short pauses in CPR while you move a patient, which is unlike what we would do otherwise. Again, with the idea being that in their hypothermic state, their metabolic rate has slowed and that they can tolerate that. So the burrito wrap is you put heat first around the chest, secondary in the axilla, thirdly in the back. Those are your priorities. You wrap them in plastic, Mylar, whatever you have. You wrap them in a warm sheet, and then you wrap more plastic or Mylar around that. With ACLS, the medications don't circulate, they don't get metabolized, and if you give repeated doses of epinephrine, it's just going to sit there until you resuscitate them, and then suddenly they're going to get this flood of epinephrine, which again could precipitate arrhythmias. So you want to avoid using repeated doses right away as per the typical ACLS protocol. And if you are unsuccessful at defibrillating, you can do one shock, you can do a series of 3 shocks. Either would be acceptable. I would probably do a series of 3 shocks, but if you don't get them after 3 shocks, you're not going to defibrillate them until you warm them up first. So you can try a few rounds of defibrillation. If that doesn't work, then you need to continue CPR and transport. So this is the pseudo PEA that I kind of talked about, and you don't have to be a ultrasonographer, I think, to appreciate that this is a beating heart that we see on the bedside ultrasound. But what you'll notice is it's barely beating, it's hardly pushing out any blood, and you're not going to feel a pulse with this, but yet the heart is beating, and so you're going to have a bradycardic rhythm. You're going to call this PEA because the rate is 38 and there's no pulse. It's PEA, but it's actually pseudo PEA related to the hypothermia, and you're not going to know that until they get to the hospital and we do a bedside ultrasound looking for pseudo PEA. So if they get to the hospital, there's ECMO, the extracorporeal membrane oxygenation or cardiopulmonary bypass. Those two are different, but you can think of them as being similar. And as much as they both will support your cardiac output as well as oxygenation and will warm the patient up. So this is the gold standard for how you would try to resuscitate a hypothermic patient. But it's kind of a big deal to get ECMO going. We don't do it on everybody. We have to decide who it is we're going to do ECMO on. And so there's something called the HOPE score, which helps us decide whether a patient is a candidate for ECMO. And this is the HOPE score that I did on our Coast Guard woman using the data, and her probability of survival is 2.5%. If you warmed her up on ECMO, the odds of getting her back and surviving is 2.5%, and her having intact neurologic status, it was going to be much less than that. So we use the threshold of 10% to decide whether we would put somebody on ECMO. Other things that we can do if we don't have ECMO, but we want to resuscitate them in the emergency department, is we can do thoracic lavage, which is where we place 2 chest tubes and we run hot water through one and let it drain from the other. You can irrigate the bladder with warm water. We have the esophageal cooling device, which we use to cool patients down after they've had a STEMI, but you can actually use it to warm them up also. And so it looks like this, where it's essentially like a nasogastric tube that has water going down and water coming back, and so it irrigates and warms all through the chest. And if somebody is truly hypothermic, you're going to have a tough time getting access, and I'd recommend going straight to a humerus IO. And you can give them warm fluids, but unlike hyperthermia, it's less effective in warming somebody up, just because you don't have the BTUs in that warm fluid to really make much of a difference. So warm fluids will help maintain somebody once you warm them up, but in and of itself is not going to be enough to warm somebody up. So if somebody comes in to the emergency department, this is how we'll decide whether we're going to continue with warming them. And if we think that they have drowned, then we will not continue to resuscitate them. And so this is kind of my approach to somebody who comes in the emergency department hypothermic. And that's the end of my talk. And I did it under 45 minutes. So Steve, I'll bring it back to you and open it up if there's any questions.
Thanks, Dr. Weiche. Few questions. One is, when we talk about defibrillation, and there's been talks and lots of research done, and with our EMTs, if they have their AED, they put it on, and I know you mentioned you should continue to defibrillate. Can you go a little bit more detail about that? And the second part of the question is the airway with using iGel and our new EMA device, and how important that might play in patients' resuscitation.
Yeah, so the first question was about the defibrillation, and then the second question was about using the MSCO2 device. And so with the defibrillation, just as with these patients, you know, I would place the AED and I would do your initial 3 checks and shock if indicated, but I wouldn't continue to shock after you do your 3 rounds. So if you've done 3 and you haven't gotten them back, and now you're cycling again, and it's telling you shock is advised on your 4th round, there's no utility in doing it. The reason why you're not getting them back is because they are hypothermic. And so you are not going to be able to get that myocardium to respond until you warm it up first. So that's one of the ways that the ACLS algorithm is different in a hypothermic patient. And you raise a good point about how useful the EMA device would be in a patient like this. So the whole reason for us monitoring the CO2 is because we recognize how important it is to not hypoventilate, but also not to hyperventilate, particularly in this situation where we are concerned about brain perfusion and the effect of hypocarbia on brain perfusion. So it'll be really important that you ventilate at the correct rate. And so, as I said, not only is the brain metabolism down, your entire body's metabolism is down. And so you will not need to ventilate as fast as you might normally because they are hypometabolic. Their metabolism is slowed down. So that's when the EMA device is going to be really important, is that you use that EMA device to determine how fast you ventilate. So good questions.
One other question about oh God, I just forgot. I'll come back to it in a couple of seconds. Anybody else have any other questions that you want to ask Dr. Weiche? And Dr. Welch did join us, and I don't know if Dr. Welch wants to add anything to the discussion.
I don't have anything in particular to add. I just really like this talk, so thanks, Dr. Weiche, for doing it. Yeah, this is something that is always controversial on how far do we go, and did they drown or did they get hypothermic? And so I think this is a really good kind of distinction to make and really useful. So thanks very much, Dr. Weiche, for putting it together and teaching us.
Well, I think it's important also because of where we're at geographically. This is a seasonal issue for most people, but for us, we pull people out of the sound every year, and the sound, it varies. It's colder up in Birch Bay, a little warmer down by Anacortes, and we're kind of in between here in Bellingham Bay, where we're 47 degrees, and it does warm up in the summertime. But for most of the year, the bay is cold enough where we have to consider whether they may be hypothermic. So it's kind of a year-round issue for us, and primarily related to the sound. So even though spring has sprung and the weather's looking nice, we still are at risk, maybe even more now that people are going to start heading out in the water of pulling people out of the sound and having to make this decision.
Thanks, Dr. Weiche. I did remember my question. It was regarding, in the past, and when we did a lot of cold river rescues, it was real important to get a temperature. Something that I think you might have mentioned a little bit in the about filling, but how important it is for our EMTs and of course our paramedics to grab a temperature before or right before resuscitation starts or during, whatever it may be. Does that play a role?
Yeah, I mean, there's no downside to getting a temperature. I would certainly get a temperature, but I would just strongly caveat that with what I led with in the discussion, in that your temperature is going to be wildly variable depending on where you get your temperature, and that not all thermometers are accurate at a low level. The gold standard for measuring somebody's temperature when they're hypothermic is to place an esophageal probe 2/3 of the way down the esophagus, because what we really want to know about is what's that core temperature right next to the heart. So you can get a temperature that's going to kind of give you an idea of a ballpark. But in that slide where I was making the distinction between mild, moderate, and severe hypothermia based on the temperature, you're not going to know that in the field. that's the value of that AVPU scale, because that doesn't require that you get a temperature. That just requires you recognizing that they were in an environment that potentially caused hypothermia, and what their mental status is going to give you an idea of what their cardiac risk is. So, so yeah, grab a temperature, but caveat it that it may not be accurate, but at least it's going to, ballpark you as to whether hypothermia is even a consideration. Most of whether they're hypothermic or not is in the pre-hospital setting is going to be mostly a clinical decision based on the circumstances rather than what the temperature is. So I wouldn't rule it in or rule it out based on your temperature. And then the other thing that I maybe should have emphasized a little bit more for the pre-hospital folks is I threw that up there, that HOPE score, which helps us determine whether we would refer a patient for ECMO rewarming. And one of the key categories on that for determining whether we are going to proceed with resuscitation was whether there was any asphyxia or not. So that is a historical bit of information that we will need to use clinically, and we need to get that from you folks. So what I'm talking about is when you rescued this person, were they face down, like both of our cases that we presented today were? If they were face down with their face in the water, then they were asphyxic. They weren't head up. In the video that I sent you with that we went over with Dr. Popsicle, the part that I didn't show was that if he was stuck on the ice and he's getting weak and he can't get out, the best he can do is to let his arms freeze to the ice and keep his head out of water. There's been cases of people's beard getting frozen to the ice, and that kept them from sliding in the water and being able to be successfully resuscitated. So if you are going to be successfully resuscitated for hypothermia, your odds of that are greatly diminished if they were asphyxic. And again, the asphyxia part is going to be based on the story you tell us of how you found that person. So what I didn't show you on that HOPE score was if there was asphyxia associated with her event, as there was, as she was found face down, her odds of survival were with ECMO was 2.5%. But if she was head up in that same situation, her HOPE score would have been 10%. That's right on the edge of considering resuscitation. So in this case that we discussed today, whether what you tell me about what her position was when you found her is going to determine whether I'm going to call the code right there or whether I'm going to continue for a prolonged resuscitation. So that's a very key historical part of this that I want you to keep in mind and be sure you are able to articulate that.
All right, well, I've got two more questions for you. And I guess one of the questions is, what do you wish more people, or maybe if there was a public education program that we create from the districts or the departments to the public, we could talk more about and knew more about cold immersion. Since we're up here in the Pacific Northwest, is there something that we could create, or is there something particular that we should maybe highlight on our websites or Facebook pages, or even something maybe us as EMTs and paramedics should know?
Yeah, well, I think probably the key is still the same thing that gets hammered, and it's the importance of wearing a life jacket or a PFD, and the importance of wearing one that is going to allow you to be unconscious with your face up. So your odds of survival will go from 15 minutes to 6 hours potentially if you have a PFD that allows you to be hypothermic without asphyxia. So that's probably the number one message that could make the difference for people.
And I just have one, I guess, personal or from a physician standpoint. Has there been any patients that you've treated that an outcome really surprised you regarding a cold water immersion?
I will say that I've treated a lot of cold water immersions, and all of the ones who arrived dead stayed dead except for one. And that was on November 17th, 2007, when my best friend and colleague came in from the sound, pulseless and apneic, and I was his physician, and we successfully resuscitated him in the operating room on bypass, only to do the honor walk 3 days later to donate whatever organs were still working. Because he was non-survivable. So most of the time when we get patients from the sound, they've drowned. And so really what I hope to do through this education is not attempt to resuscitate more people, but actually to give permission to not resuscitate these people and to better understand the ones that are survivable and the ones who are not survivable. It's not only is it just a lot of time and resources for an already stressed emergency department, I'm not so certain it's the compassion or the right thing to do. I remember a 3-year-old who came into the emergency department who drowned in a swimming pool, and the axiom of they're not dead until they're warm and dead, particularly with kids, was followed, and I'm not sure that was the right thing to do. And I think if we understand the difference between hypothermia and drowning, I think we will make better decisions as to who we resuscitate and who we do not resuscitate.
All right, any other questions out there? All right, well, hearing none, Dr. Weiche, I really appreciate you taking some time to talk about cold water immersion, and maybe we should think about this when we come, not for cold water, but when ski season starts up next year, maybe doing a preemptive conversation and maybe EMT, BLS focused training on things that happen up on the mountain.
Yeah, we can talk about that because it is a little bit different, and some of you might have been there. I did give a talk for the ski patrol and trying to distinguish hypothermia from environmental causes up on the mountain versus being caught in an avalanche versus snow immersion. Those are all 3 different mechanisms that are treated 3 different ways, and so there are some subtleties that are different. And again, some of it is the same, but this talk today is specifically about cold water immersion and specifically about the unconscious patient and who to resuscitate and who do we not.
Well, again, I appreciate it. Thank you, everybody, and we'll see you on the next one. Everybody be safe out there.